Good afternoon. I'm Dr. Andrea Noya. It's an honor for me to be here on behalf of my institution, Orsi Academy, Azor Hospital, and my professor, Alex Motri. The video has volume, please.
In the management of renal carcinoma, including complex cases such as T3V kidney tumors. We present the case of a 78-year-old male patient, obese with a muscle mass index of 32, on hemodialysis due to chronic kidney disease, who present persistent elevation of a C-reactive protein, for which reason an abdominal CT scan was performed, in which a renal interpolar lesion of 7.7 centimeters in diameter was observed, associated with thrombus in the ipsilateral renal vein. Both kidneys also show a significant atrophy and multiple renal cysts. Diagnosis: it was decided to perform a robot-assisted radical nephrectomy and thrombectomy. Under general anesthesia and in the left lateral decubitus position, docking of the Da Vinci Xi system was performed. After descending the colon and the Kocher maneuver, the renal vessels and the Vena Cava were dissected, as well as the hypogastric vein, which was clamped and sectioned early. After identification of the structures and their isolation, we proceed to the placement of basal loops for clamping, which is carried out using the Rommel tourniquet technique. The contralateral renal vein was isolated, as well as the distal and proximal vein, confirming with ultrasound that the thrombus has been included in the clamped section. We start the cavotomy in the anterior surface of the cava. We remove the tumor thrombus with unblocked extraction, and after this step we cut the posterior face of the renal vein and also early vein of the thrombus. The vascular transit is reconstructed with two running hemisutures of non-absorbable monofilament. After verifying correct hemostasis, the nephrectomy was completed and the surgical specimen was removed. The surgical time was 200 minutes with contralateral renal vein climbing time of 22 minutes. The blood loss was 800 milliliters. The patient discharge was on the 7th postoperative day. The pathological reports showed a 4-month grade 3 renal clear cell carcinoma with other invasion and extension to the renal vein PT3B. Based on our experience and following previously published studies, we conclude that robotic-assisted surgery is a viable and safe option for T3B kidney tumors, performed by skilled surgeons in high-volume centers to optimize outcome.
Very, very nice demonstration. So just a couple of questions. One thing which I noticed was probably you must have edited that, was you didn't inject or instill heparinized saline before you released the clamp of the IVC. Do you think it was important to do that, or you have not shown it here because it may be having some air and the possibility of air because it's a big cavotomy. Yeah. So normally you just flush the IVC with heparinized saline before you release the clamp. That was one thing. The second question was the UAC has one of the largest series, the University of South California, and their approach is IVC first and kidney later. Do you also believe in that?
Thank you for the questions. For the first one, in our experience, we never use saline serum. No, never. And the second, we always go in this way. First, we do the Cava step, and then the kidney, because in this way we have a perfect exposure of the renal vein, and it's easy to release at the end the kidney directly.
I'm not sure what is the opinion of the house. Like even when we do transplant and before releasing the venous clamp, we tend to flush the saline in the empty vein. I can invite some opinions on the same thing from the seniors. We have got some senior people here. Dr. Gupta?
I agree what you are saying, that it is always better to flush with the heparin saline, the vena cava, before you put the last stage, you must flush that.
Yeah, we also fill with the hep saline before taking the last stitch, and also wash it nicely so a little bit debris which is left will come out.
One thing more probably I have missed in your video, artery. How do you ligate the artery first? Do you go to between the vena cava and aorta and ligate the artery there?
Thank you for the question. We always try to dissect all the cava and the renal vein. Of course, the renal artery, we clamp the renal artery first, and then we go to the cava open and the thrombus remove.
By your approach, if let's say it's a left-sided tumor thrombus that is going up to like level 2 you showed. One of the reasons to do the thrombus first is so you don't have a PE from inadvertent thrombus floating going to the lung straight. So,
yeah, thank you. Yes, this is completely true. It's better to avoid the escape of the thrombus, but we don't have experience in left kidneys, so we only have experience in right kidneys.
Right kidney. Okay.
Yeah, also because it's the most.
What about the moderators? What do they do for the left-sided renal vein thrombus?
So for left side, we would invariably use a stapler. So first we attack the IVC from the right side itself, reach the left left renal vein insertion, use a stapler there. So finish and then finish the IVC thrombectomy, but then redock to go to the left side and finish the procedure.
Got it.
Hello, I'm Dr. Deepak Kaddu, presenting from Manipal Hospital, Whitefield. So this is total robotic approach for level 4 IVC thrombus with renal cell carcinoma. This is a CT scan showing a left renal mass of 70-year-old female with the IVC thrombus extending up to the just below the atrium. So it is level 4A. So in the first left flank up position in the urology department did the left radical nephrectomy with the renal vein stapling and the pancreatic tail resection specimen delivery through the financial incision. And the ILC team, that is integrated liver team, they did the left liver lobe mobilization. So this is the stapling of the, after completing the artery part, stapling of the renal vein, then the dissection of the left lobe of the liver, gastrohepatic ligament. So then we go up to the right flank up position with the urology team doing the dissection of the left renal vein stump, renal artery looping, IVC dissection, whereas the ILC team is doing the right lobe of liver dissection and short hepatic vein clipping. You saw the position and the port placement. So we are dissecting behind the IVC here, and you can see the stapled left renal vein margin. So this is the renal artery dissection, looping of the renal vein on the right side, and dissection of the right lobe of liver. This is clipping and cutting of the short hepatic veins for better exposure of the infra-hepatic IVC. So then we go again change the position. So this is the third time position change, reverse Trendelenburg, with the integrated liver team doing the looping of the suprahepatic IVC, supradiaphragmatic IVC if required, porta hepatis control, whereas the urology team doing the IVC thrombectomy and IVC suturing part. Then this is the port placement and the position. So this is the falciform ligament is incised with the for the liver mobilization. This is the suprahepatic IVC dissection. So we are looping the suprahepatic IVC with the infant feeding tube. We double loop it and put a hemoclip there. If required, we release the dissect the central tendon, taking care in not injuring the diaphragmatic vein. And also in some cases, like we did 2 level 4 cases. In one case, we have to incise the pericardium and get to the aorto-caval junction to loop it and put a clamp over it. So this is the looping at the junction of cavo-atrial junction. So this is the Pringle maneuver. So here we use the modified Foley's catheter to loop the porta hepatis. Now this is the infrarenal IVC clamping. Then the right renal artery is clamped. Then the right renal vein. Then the porta hepatis clamping and tightening of the control. And the whole procedure is monitored through the transesophageal echocardiography, as well as the drop-in probe to confirm the exact extent of the thrombus so that we can place our superior clamp just above the liver. So this is below the diaphragm once we know the position. So here we are doing the IVC thrombectomy. Now the urology team comes into way. So during the IVC thrombectomy, we are also resecting the stapled margin here, as this is a left side renal cell carcinoma. So we are removing the stapled margin. So you can see the thrombus attached to it. So thrombus is removed in entirety. It is also confirmed with transesophageal echocardiography and the drop-in probe again that there is no residual thrombus. Then all the clamps are released and we are seeing that there is no thrombus residual. So we suture generally with the CV5 TTC9 Gore-Tex suture. This is very easy to handle. We also flush with heparin. We use a suture from below and suture from above and tie it in the middle to avoid the bursting effect. And also we confirm the watertight closure. So after that, all the clamps are released. So here, so before suturing, we release the suprahepatic clamp and apply the clamp in the suprarenal part. So in this case, the total operative time was 490 minutes, console time was 320 minutes, IVC clamp time was 22 minutes, porta clamp was 11 minutes. So we have a case series of around 22 cases in which level 2, 3, 4 thrombus are included. So total operative time is 274, that is median, and console time median is 146 minutes. IVC clamp time is 17 minutes. So which is almost similar to this case, which was level 4 thrombus. So moving forward, in this case, the perioperative parameters were the blood loss was 375 ml, and the HB drop was 1.8 gram. Creatinine was 1.23 milligram percent up in post-op day 1. At day 3, creatinine was normalized. Drain was removed on day 7, and the patient stayed up to 8 days and then discharged. So we have this HPR was clear cell carcinoma, Furman grade 2, hilar node negative, pancreatic. So this is a short, I think the audio is not, I think it is not audible. So this is the patient giving the testimonial saying this is 2 years after the surgery, patient is doing fine. She is the patient, 71 year when she was operated, now she's 73 years. So we have a total series of 36 patients in which we did the IVC thrombectomy. 22 were completely robotic, 8 were converted to open because of reason like vascular bleeding or the inoperability, or in the beginning we were not confident of doing the level 3 and level 4 with the robotic, and 6 were started completely as an open. So out of these 22 patients who underwent level 2 to level 4 IVC thrombectomy, there was no perioperative mortality. Only 2 patients had transient renal functional worsening, which recovered spontaneously, and median stay was 5.5 days. So mean follow-up was 22 months. Out of 22, 17 patients are alive. 5 died due to 3 due to metastasis, 1 due to local recurrence and metastasis, and 1 due to old age. So this is our series of IVC thrombectomy, robotic plus open. Thank you.
Thank you, Deepak. I think we are really pushing our limits, going all the way to level 4. One question, you have got a series of 22 patients, all at a different level of thrombi. Did you offer neoadjuvant chemo or ICIs for any of these? Because it's a well-established therapy, because level 4 can be downstage to level.
Yes, sir. Only if we find if the local organs are involved, like pancreatic tail, if it is involved, then we can offer. But still, till now, in all of the 36 patients, we have never offered.
Because it is
we are awaiting one patient with the neoadjuvant chemotherapy. We will see in that patient.
Yeah, even the disease-free survival and overall survival with neoadjuvant with IVC thrombus is improved by 20 months in all the series. So I think that is one thing, like especially for level 4, you may be able to downstage these tumors, with TKIs.
Okay, so most of the tumor thrombus we found as they were bland thrombus, and some of the thrombus were like they were having the tumor positive, but we will need a biopsy if we want to go for a neoadjuvant therapy. So I would better to go ahead with the surgery followed by the adjuvant if required.
Sure. Professor Ankumar, sir.
Yeah, 2 questions. One is that like your thrombus came out easily, but doesn't happen in all cases. If it is adherent, because I have seen you have not mobilized the right lobe of the liver. You have gone suprahepatic and you were just took the caudate lobe. And then that part, so rest of the part was still not mobilized. Suppose it was adherent, then how you would have approached?
Yeah. So, sir, the case selection is very important. So we go through the CT properly. If we see the thrombus is adherent, we will do MRI. We find any IVC wall invasion, we will directly go for open. But here I am short of time. I have not shown the complete dissection, but we have mobilized the right lobe of liver completely and also on the left side. Yeah. Short of time I have not shown, but we have done the complete mobilization. And only there are 2 kinds of thrombus. One is the porridge thrombus and the saddle thrombus, or so if the saddle thrombus is there, it can easily come off, like sausage thrombus. If we pull, it will easily come off. If porridge, it will come by bit. So our case selection has to be proper. So in 6 cases, we have directly gone for open, considering those things.
And how did you make sure that whole thrombus has come out? Like we used to put, we often put flexible cystoscope to go inside and see the tip. Because so the intracardiac esophagus, that will only tell you about the thoracic part. This part, either you put the ultrasound but once it is opened, you may not see anything. So what you do, put a flexible cystoscope quickly and look at inside, and it just shows that everything is out.
Yeah, sir, sausage thrombus, there is no need to do because it comes in entirety. But porous thrombus, I will go for the flexible cystoscopy and put and check the IVC till the liver level. Of course, I can do that. We have done in certain cases.
And if you have a tumor on left side, then how many times you change the position?
Yeah, so in this case, we have changed 3 times. This is a thin patient. In obese patient, we might have to change 4 times. So 1 time on the left radical nephrectomy with stapling. Then we have to do the right flank up and dissect the IVC and the right lobe of the liver. And then we are again to do a supine reverse Trendelenburg and take the diaphragmatic incision, suprahepatic IVC control. And in this patient, in the same position, we did the IVC thrombectomy. Patient was thin and suturing was done. But in certain cases, we have to again change to the right flank up position for better IVC suturing and thrombectomy. So maybe 3 to 4 times for the left side.
Shivam from Jaipur.
Thanks.
So you said that this was a level 4 thrombus.
Yeah.
So level 4 thrombus is usually supradiaphragmatic or atrial, right?
Yeah.
So how can you reach supradiaphragmatic by just going suprahepatic?
So in the video I have shown, we have incised the central tendon and we have gone supradiaphragmatically. We did 2 level 4 thrombus. In another case, we have even incised the pericardium and taken control over there. And we have confirmed the proximal extent of the thrombus with the drop-in probe. So we have gone, when we adjust the clamp, the thrombus slips down.
No, not necessarily. If it is atrial,
Yeah.
unless you do a circulatory arrest or
If it is atrial, we have to do a circulatory
you would not
arrest.
be able to
Yeah,
do.
that case we don't choose for robotic. We
Right,
go for
right.
robotic.
Thank you, chairpersons, and thank you, Verticity Foundation, for this wonderful opportunity to have an interspecialty kind of discussion and meeting. And to Dr. Bhandari for his innovative idea of inviting the medical students to have that presentation. It was wonderful. So congratulations for that. Now, mine is not a very difficult case, but what I want to say is that in at least Deepak's case, in the earlier case, can you hold on further? Yeah. In the earlier case, we saw that if there was a thrombus which migrates into the pulmonary vessels, then suddenly everything goes haywire. So it has to be a very clearly understood, and as you rightly said, patient selection and the confidence of the entire team and a pre-operative discussion warm-up is something very important. So I'm going to take you through the tips and tricks. This is a 65-year-old male. You can play the video, please. A 65-year-old male who presented with a right-sided bilateral renal mass. In fact, the right side it was 7 to 8 centimeter mass. The video has gone back. Can you play the video? Yeah. And on the left side there was a 3 centimeter mass. On the right side it was an 8 centimeter mass, which was reaching all the way into the IVC for about 3 centimeters. And we decided, okay, this is the first one to be dealt with. So you can see the imaging where you can see the lower polar renal mass and the thrombus, which is pouting into the IVC. It will be more evident in the subsequent coronal sections. So here in the coronal section, you can appreciate, there you see the thrombus reaching almost up to the subhepatic location. So that was the level of thrombus. So we had a pre-operative preparation of discussion of who is going to do what in case there's a problem. So the ports are typically lateral and cranial, so that you have good access to the liver surface. First step is obviously mobilization of colon, so that will go quickly. Here, one important thing is you would have a lot of collaterals. You see one collateral from the duodenum onto the IVC, which has to be clipped. These collaterals are very dangerous if they tend to bleed, so one has to be very careful here. And approach the IVC first, not the kidney. So you don't mobilize, don't move the kidney at all. Just reach the IVC, try to take the suprahepatic control, and then you can do the rest of the stuff so that the risk of thrombus migration is minimized. So we're not mobilizing the kidney, we're just attacking again another collateral you can see. So these are big collaterals and they cause torrential bleeding and loss of confidence. So it will be very carefully dissected and clipped. Here I would say one tip, fourth arm acts as a very good retractor. You can see the fourth arm retracting right above the IVC, the caudate lobe, and giving an access to the subhepatic space. Again, the caudate vein is seen, a small vessel which you can clip. Here you see the bigger caudate vessel, so that has to be clipped. So the major tip is that you need to be careful here because there are a lot of collaterals all and around the IVC in a thrombus patients. Once you do that, you see do an intra-op ultrasound, see the thrombus that it is seen rounded off, so there's nothing beyond it. So you're more confident. Now, once you have located that this is the level of thrombus, in the subhepatic part of IVC, first step would be to lift the IVC and go behind the IVC and take the suprahilar control or subhepatic control, so that the risk of this thrombus dislodging and going up is decreased. So this is kind of standard what we do in open as well. But the only thing is you have to be very, very careful and to prevent the thrombus up migration at any cost. Then second thing would be to attack the left renal vein to find a plane here. Sometimes you'll have a lot of lymph nodes here, which might cause a problem. And here you see the gonadal vein is opening into the right renal vein. So we had to clip it. Otherwise, generally you might actually get away without clipping it. There you see another collateral, which is again being clipped. And there you find the renal artery. So you can attack the renal artery right at the interior caval, or like here we found it here, so we just clipped it here. Once you have done that, go very close to the renal vein and take the infrahilar control. As if you go lower down, you would hit a lot of lumbar vessels which tend to bleed as you open. Now, once you have taken all the controls, mobilize there's another collateral you can see. Mobilize the IV, see the lateral wall of IVC close to the kidney so that you have something to play around when you cut it and open it. Again, do an ultrasound to see if that your thrombus has remained the same as it was. Now clamp the IVC from about downwards, suprahilar, then the left renal vein, and then the infrahilar. So once the clamping is done, open the IVC judiciously. Don't hesitate here that you make a small opening. Open it so that the entire thrombus comes in toto. That's the most important thing, because if you just open a little bit and you tend to break the thrombus, you're not an oncologically correct procedure. Again, you can see the bleeding. That's because of the lumbar vessels which tend to come up. Here you can see the thrombus is completely intact and smooth. Yeah, so the thrombus is clearly seen, which is this is probably an ideal case to do it. Otherwise, as somebody pointed out, infiltration of IVC and sticky thrombus, I don't think we should really attempt such procedure, because you don't have a control of tumor spillage and things like that, which may be oncologically devastating for the patient. Again, we are using Prolin here. This is a 5-0 Prolin, but I agree that Gore-Tex is a better choice for repairing the IVC. And lastly, we flush the IVC with hepsaline. And we typically have, to prevent the bursting effect, we take a knot here and then we come back again to have a double layer suturing. And then once you remove all the clamps, there will be minimal ooze, and I think for transplant surgeons, it is very easy to know that this kind of ooze, it will subside. Just put a gauze there and it will go off. Now you take care of the kidney and do the procedure. It's always a team which wins. It should not be done with one surgeon at the behind, because unless you have a good team, any eventuality, suddenly there's a bleeding or something, it has to be a team which should know what to be done. Thank you very much.
Excellent demonstration, Ravi. I think you said it right. It's a teamwork, and I think the teamwork starts well before you go ahead with the surgery. So, a couple of cents from my side. I think one is, I think we have to involve allied branches. So, as I said, neoadjuvant chemo in most of the IVC thrombi, we have to take their opinion. Number two is, in such patients where there is a lot of collaterals, I think angioembolization within 24 hours before, it helps. We have done it in a couple of patients, and it makes really your life easier. And using a Satinsky, especially at the distal end of the IVC, gives a good control. So you have got a laparoscopic Satinsky. Because I feel that if you use only the loop, or if our bulldogs are not that reliable, they can be relatively loose. So I think Satinsky is another thing which we can think of using.
No, I think it's Bulldog or Satinsky. I'm not sure whether it makes a real difference, but we would take that. We did not have a problem as of now, so we are happy, lucky that way. Regarding neoadjuvant chemotherapy, I am not sure. Angioembolization, I agree. It's basically preoperative CT. If it shows a good amount of lymphatics and a lot of collaterals, we do angioembolization. Here in this case, we did not do it because it looked more or less okay. Regarding neoadjuvant chemotherapy, I can actually opinion of the house whether how many of them actually use. We don't use it honestly because I believe one, it delays the surgery. Second, that literature regarding its downsizing is not very clear. There are anecdotal reports only, so we cannot really take the patient through that first exhaustive therapy and then have no outcome. And probably I don't know whether it's after surgery how difficult it becomes to do surgery after a neoadjuvant.
Correct. So we have anecdotal. I have seen like level 4 downgrading, downstaging to level 3, 3B. Okay. The other advantage is, as I said, the overall survival. There is a definite improvement.
So we add adjuvant.
Adjuvant.
We always add adjuvant in such way. Any PT3 and above, you would add adjuvant for 1 year. We already have an evidence for that.
Yeah.
But neoadjuvant, a little. But I think you can have opinion of house, whatever.
Shiva, I agree with you. I think there are no evidence actually to give neoadjuvant chemo for patients with IVC thrombus. There may be some anecdotal reports. Embolization also, there are some anecdotal reports. They also may downgrade sometimes the level of thrombus. Secondly, the question was to Ravi. We know the recommendation, if there is an IVC thrombus, we need to do a radical nephrectomy, right? But there are case reports when, like in this case, it was, if there had been no IVC thrombus, you would have done a partial nephrectomy, right? So in some cases, can you do a partial nephrectomy with IVC thrombectomy?
I mean, anecdotally, once a while, yes, but I have never done it. So I'm being honest here. I've never done it because I always feel scary. And more often than not, if the other kidney is normal, we don't even think about it. Because at the end of it, we have to be oncologically 100% sure that we've done a good job. In fact, even doing robotic, we started almost 2 years back after 8-10 years of experience because we did not want at any point that we go haywire with the oncological principles. That's my honest take there.
So there are case reports where they have that iron, particularly in cases where they think that the tumor may not appear that malignant, right? It may be benign also, and they have associated IVC thrombus.
Fair enough.
Right. Thank you.
Sir, 2 questions. How you follow up these patients over a period of 5 years or 10 years?
Sorry,
and how do you follow up the patients with the imaging or PET scan? And second question, this angioembolization, does it make your dissection difficult with edema? And what is the time after which you start for surgery after the angioembolization?
So I'll answer the second one first. Angioembolization, we do about 70% of cases of IVC thrombus, they do undergo angioembolization. And one change it does is, especially in open surgery, that the small venous collaterals, they tend to have a lower pressure. So they don't start bleeding the moment you open it. So you can easily tackle them. Secondly, the plane around the kidney, there's a lot of, because of angioembolization, there's a good plane of dissection. It's kind of watery plane, you can easily get around it. The only flip side of it, people say that if you're angioembolized, the thrombus becomes friable and there's a higher chance that it might migrate and if you're not careful in handling. So for us, always the principle is attack the IVC first, irrespective of right or left. Even if on the left side, we go on the right side, staple the left side, and then finish the tumor part. So with that principle, we never had an embolization on table, at least. But so I think that answers. Secondly, follow-up of these patients, if it's a PT3, we typically would give adjuvant checkpoint inhibitor, and not affordable, we give TKI. And these patients follow with a 6-monthly imaging, at least the first imaging would be at 6 months, and then annually based on what we find.